Androgen insensitivity syndrome, AIS. Alice Mann, Maureen O'Brien, Elizabeth Ruckert. What is AIS? A genetic condition where affected people have male chromosomes and male gonads with complete or partial feminization of the external genitals. An inherited X-linked recessive disease with a mutation in the androgen receptor, R, gene resulting in functioning Y sex chromosome. Abnormality on X sex chromosome. Types: gays, completely insensitive to R gene. External female genitalia. Lacking female internal organs. Pais, partially sensitive varying degrees. External genitalia appearances on a spectrum, male to female. May, mildly sensitive, rare. Impaired sperm development and/or impaired masculinization. Also called testicular feminization. Androgen insensitivity visuals. Number 2. Image 1, a woman with an XY chromosome pattern but insensitivity to androgens. Image 2: a newborn genetic male, 46 XY, with complete androgen insensitivity syndrome and female external genitalia. Number 1. Classification of AIS forms. Exists a long continuum depending on degree of mutation in R gene, Quigley and French. Grade 1, Pais. Male genitals, infertile. Grade 2, Pais. Male genitals but mildly under-masculinized. Grade 3, Pais. Male genitals more severely under-masculinized. Grade 4, Pais. Ambiguous genitals. Grade 5, Pais. Essentially female genitalia, with enlarged clitoris. Grade 6, Pais. Female genitalia with pubic/underarm hair. Grade 7, gays. Female genitalia with little to no pubic/underarm hair. History possibly first mentioned in the Talmud, 400 BC. Speculation of whether Joan of Arc, 1412, and Queen Elizabeth I, 1533–1603, had AIS. First reported 1817. Steglainer described apparently normal woman with undescended testes. Diafanich, American geneticist, 1906. Hereditary pattern. Pedersen and Bonnier 1937. Concluded that affected persons are genetically male. Wilkins, 1957. Found tissue unresponsiveness to androgens. Androgen receptor gene cloned and sequenced in 1988. Statistics affects 1 in 20,400 people. 2/3 of cases inherited from mother. 1/3 of cases come from a spontaneous mutation in the egg. No effect on life expectancy. For a carrier woman, there is a 1 in 4 chance in each pregnancy that the child will have AIS and a 1 in 2 chance if the fetus is male. No racial differences. Normal sexual development. Male. Sex chromosome equals XY. Gonads equals testes. External genitalia equals male. Female. Sex chromosome equals 20. Gonads equals ovaries. External genitalia equals female. Normally chromosome sex determines gonad sex, which determines phenotypic sex. What happens in AIS, androgen receptor gene? AIS results from mutations in the androgen receptor gene, located on the long arm of the X chromosome, XQ11Q12. The R gene provides instructions to make the protein called androgen receptor, which allows cells to respond to androgens, such as testosterone, and directs male sexual development. Androgens also regulate hair growth and sex drive. Mutations include complete or partial gene deletions, point mutations and small insertions or deletions. Mutations can cause cells to be less responsive to androgens or prevent cells from being responsive at all. in approximately 10% of women who are carriers for the altered androgen receptor gene. Clinical signs such as sparse pubic hair, armpit hair and delay in the onset of menstruation are commonly observed. The process of sexual development. In AIS, the chromosome sex and gonad sex do not agree with the phenotypic sex. Phenotypic sex results from secretions of hormones from the testicles. The two main hormones secreted from the testicles are testosterone and Mullerian duct inhibitor. Testosterone is converted into dihydrotestosterone. Mullerian duct inhibitor suppresses the Mullerian ducts and prevents the development of internal female sex organs in males. Wolffian ducts help develop the rest of the internal male reproductive system and suppress the Mullerian ducts. Defective androgen receptors cause the Wolffian ducts and genitals to be unable to respond to the androgens testosterone and dihydrotestosterone, AIS fetus development. Each fetus has nonspecific genitalia for the first 8 weeks after conception. When a Y-bearing sperm fertilizes an egg, an embryo is produced and the male reproductive system begins to develop. Normally the testes will develop first and the Mullerian ducts will be suppressed and testosterone will be produced. Due to the inefficient R gene, cells do not respond to testosterone and female genitalia begin to form. The amount of external feminization depends on the severity of the androgen receptor defect. Gaze, complete female external genitalia. Pais, partial female external genitalia. May, mild female external genitalia, essentially male. Testing for AIS tests during pregnancy. Chorionic villus sampling, 9 to 12 weeks. Ultrasound and amniocentesis, after 16 weeks. After birth. Presence of XY chromosomes. Buccal mouth smear. Blood test. Pelvic ultrasound. Histological examination of testes, biochemical testing for carriers. Tests. 1960-70 AS, skin biopsies evaluate androgen binding capacity. Carries, 50% androgen binding. Problem, some cases skipped because mutation did not always take place in the binding region of the gene. 1990s, DNA testing. Blood or mouth cavity smears. Now. Measure length of base pair repeat region in first exon of gene and compare it to a female relative's repeat region to determine if they are a carrier. Non-biochemical testing. Maternal relatives affected by AIS. In 20 female. Delayed puberty. Reduced pubic auxiliary hair. Asymmetric pubic auxiliary hair. Reduced bone density. Treatment: surgery, debate, orchidectomy or gonadectomy. Removal of the testes. Vaginal lengthening. Genital plastic surgery. Reconstructive surgery on the female genitalia if masculinization occurs. Phalloplasty. Vaginoplasty. Pressure dilation. Clitorectomy. Debate. What age? Who decides? Treatments: hormone replacement therapy, HRT, types: form. Female, estrogen. Progesterone, sometimes take to reduce risk of breast or uterine cancer. Post-orchidectomy. Male, testosterone and DHT. Form. Oral, transdermal, implant, injection, vaginally. Prevents osteoporosis, age 10 or 11. Body responds as if it is postmenopausal, thus body density decreases and osteoporosis occurs. Psychological issues. Medical care services, geneticist and a pediatric endocrinologist. Criticisms. Lack of emotional and psychological support. Family. When to tell their children about their disorder. Knowledge of if they are a carrier and if so, guidance on whether they should have children or not. Patients. Therapy. Isolation. Registration desk of a doctor's office. Group examination. Androgen Insensitivity Syndrome Support Group, ASC. Case Study. Discovery at age 12 years old. 18 years old. Fears. Support.